So here's what's actually happening. The H.R. 1, One Big Beautiful Bill Act became law on July 4th, 2025. It's a massive reconciliation package that touches two major areas that directly impact nursing: student loans and Medicaid. All week long, you've been following on the Mahogany Dermatology blog, reading the 5 articles that we released, and even the audio on our podcast, for those of you who are really busy and you still have questions. I want to make it clear. Your DNP degree is still a doctorate. Your PhD, also still a doctorate. And our status as professionals in nursing hasn't changed. But it is true, with HR 1, this is going to impact every DNP student, every PhD candidate, and every doctorally prepared nurse navigating educational debt. But don't worry, because by the end of this video, you're going to understand not just what's changing, but how to position yourself strategically so that when systems contract, and that's exactly what's about to happen, you'll be the one who's still standing, still serving our clients and our patients, and still building wealth. If you're new here, welcome. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner and the founder of the Alliance of Cosmetic Nurse Practitioners, which is a professional membership for nurse practitioners who specialize in entrepreneurship and cosmetics. We're there to help you if you're looking to build your business on this side or start your own empire. We pick up where your on-demand weekend course or academic program leaves off, providing that ongoing coaching and mentorship. Because what do we know? We know your first question is never your last question. We know entrepreneurship is very lonely. We know that you have decision fatigue. There's so many decisions to make, and you're overwhelmed and burned out. And sometimes you need a little bit of hope. Sometimes you need a little bit of help. And sometimes you just need to be in community, because what we've learned is there's no such thing as a self-made man or a self-made woman. And the most successful people work together by keeping each other in business. So we come here every once in a while doing batch content live, answering your questions in real time. In fact, we're going to be doing 8 videos today. The 8 videos that we're doing today are your questions. This whole business, Mahogany Dermatology Nursing Education and Research, is founded on the principles of helping you all. We have specific emphasis and interest on skin of color, business acumen, and digital fluency. So we have a lot to cover. As you know, the Big Beautiful Bill is lots of pages. And so we're going to try to break it down for you in the next 30 minutes or so. Every episode, so actually right now that you're watching this, it's almost December, and that will be, now I'm starting to lose track. I think, is it 2 or 3 years on YouTube? I don't even remember anymore. But we always start the episode with our devotional. So I'm going to go open that up right now. And when you're here, please join me. Say something in the comments. I don't like to be alone. And then you can answer your question right away. And you don't have to worry about scheduling an appointment or waiting for me to respond to your email. Okay. So here's our first one. God, you know me. You know what I'm facing, what I've already overcome. Please remind me that you are near. Show me glimpses of your faithfulness in this season. Restore my hope and my joy, and teach me how to continue to place my trust in you. In Jesus' name, amen. Speaking of, I hope you all had a peaceful Thanksgiving and you were able to spend it with the people that you love and that matter the most, and that you're looking forward to some downtime as we close out the year. I know I am. Okay, so let's jump into it. Let's start with talking about student loans, because this is where a lot of the panic about professional degrees is actually coming from. So like I said, since July, starting next year, July 1st, 2026, this is what's going to change. First, if you're a DNP or PhD student, or you're thinking about going back for your doctorate, that Grad Plus loans, which I have probably been how you plan to cover your tuition and living costs beyond the standard federal loan limits. Those are gone now. Second change is there's going to be new borrowing caps. So graduate students, which is what nursing is now considered, have a $100,000 lifetime borrowing cap for direct unsubsidized loans. If you're a professional, or in a doctoral program that still qualifies, you'll get access to $200,000. And now the overall aggregate cap across all federal loans is going to be $257,000 and $500,000. So what does this mean? It means you can still borrow money for your doctorate. You're just going to hit the cap a lot faster, and you won't have that Grad Plus to fill the gap. Third thing you need to know, your repayment options just got a little bit tighter. So for new loans that are going to be dispersed on or after July 1st, 2026, Most of the existing repayment plans, Save, Pay, ICR, all the income-driven plans that we've relied on, those are eliminated. You get two options: a standard path with fixed payments over 10 to 25 years, or a new repayment assistant plan that stretches your payments over 30 years. So let's take a little bit closer look at this. So starting next summer, if you take out a brand new federal student loan, you will not have access to the repayment plans that we've relied on up until now. So let's look at what these mean. So Save, Pay, PAEE, and ICR, basically the whole family of income-driven repayment plans. Those are going to be eliminated. So instead, borrowers will have two repayment options moving forward. Now, the standard repayment plan, which is basically your traditional fixed payment over 10 to 25 years. And then this new income-based plan, WRAP, or the repayment assistance plan. Now, if you already have loans and they were dispersed before July 1st, 2026, you won't automatically lose your current repayment plan, but you will eventually be asked to switch. Most borrowers have up until 2028 to transition into the WRAP or into a modified version of IBR. If you don't choose, you'll automatically get placed into one of the new plans. So the safety net doesn't disappear overnight, but it does shrink. And if you're a doctoral student, a nurse practitioner, or you're planning to borrow again during residency, fellowship, or your DNP program, this matters because you're going to have less flexibility in how you manage your payments. You may face higher monthly payments than what Save or Pay would have given you. And WRAP, even though it is income-based, it's not the same as the old income-driven repayment plans. It has a different formula, different protections, and different forgiveness timelines. This is especially important for my NP entrepreneur friends, those of you that are building a practice, working per diem, or who have fluctuating income. Under the old system, Save or Pay, they gave you breathing room while your business grew. But under the new system, you'll need to plan ahead and build a bigger financial buffer because repayment will be less flexible. So when people say most repayment plans are eliminated, that's essentially true for future borrowers. But if you're like me and you've already been in the system for a while, then we're going to have a transition period and there won't be an immediate shutdown. And I know this is a controversial topic, and I'm not here to even get into that part of it, but I think it's a great opportunity to talk about financial literacy, financial independence, and having diverse stream of income, right? Not relying on one stream of income from one employer, one stream of income to help you get through school. Actually, every Sunday, me and my family meet. And I literally just had this conversation with one of my family members last week. I was telling him because I have 6 figures of debt when it comes to student loans. And I told him I would never recommend that to anyone because the longer you owe debt to somebody, the less time you have to gain your own financial wealth and independence, which is what this is all about. And I just think it's so much smarter to go into school with a skill that helps you make money so that you can live, but it also helps you earn revenue while you're going to school and building your business. And so any kind of skill you can gain while you're in high school or even that first year that you're out that will allow you to make money. It can be something as simple as construction, hair, I don't care what it is, cleaning, helping other students move. Get enough money so you can put down payment on some property or even rent out the property and rent out the rooms. But the whole goal is my plan recommendation would be to buy your first real estate property that has multiple doors so that you can rent out those other rooms. And those other rooms, it's called the 4321 plan. They pay for that mortgage. Use that leftover money that you're not using to save again and buy the next door, 3 doors, then 2 doors, and then 1 door. By the time you get to the 1 door that you actually live in, that you reside in, all those other doors are paying for your mortgage. But coming out the gate, the whole plan, that first piece of property should be seen as income property. So it's helping you make money. You have a skill that's bringing in money. So then you're less reliant on these loans anyway. So that's just my 2 cents that costs a lot of money to get. So let's keep going. Because the next part, the changes to deferment and economic hardship protections is where things get even more real. And I have to be honest, I've benefited from everything we're talking about today because I started school a long time ago. And I've been I used the loans for a good portion until I capped out. and then I came out of pocket. But I still have I still have a long way to go, and I would hate to see any of you have to take the same route. Okay, so economic hardship deferments. If you lose your job, and lots of people have been losing their job, even in healthcare. If you hit financial hardship, can happen to any one of us. Being a student is financial hardship, right? Even our physician friends have been talking about after they finish residency and they're waiting to take boards and they're waiting to start their new job. And then, once you start the new job, you get credentialed, even getting credentialed, getting the new job, and then getting that first check, you're talking about months. And so what are you doing in between that time to survive? And I never even really thought about it. Certainly as nurses, we go through that too, but typically we're working as we're transitioning from being a nurse to a nurse practitioner. So I don't think it's been as much of a struggle as it is for our physician friends. Now, certainly if you're in one of the nursing programs, maybe you're coming out straight as graduate, so you haven't been working. I mean, it can still be happening. We can still see it in nursing, but I think it's maybe 50-50. Whereas I think probably it's more the exception in nursing, whereas I think it's the rule when it comes to physicians, and what they're doing to survive. And so they have been borrowing money, going back home, taking out loans, using credit cards, and unemployment. So that's a very important conversation that needs to be had, definitely. But all this just comes back to the importance of financial literacy, which we need, because if you're going to a professional school, you're going to come out making a lot of money, maybe more money than you've ever seen, and you need to have the acumen to know how to manage that before you actually see it. So whether it's just because you're going to be a working professional or because you're going to have your own business, either way, it's just something that's really important. So if you are taking the long way, or you have room in your schedule, and you're thinking, what other courses can I take, other books I can read, other conferences I can go to, conventions, whatever you want to call it, I recommend anything that has to do with financial management and another language. That's just my advice. So let's see. So the deferments. So for loans that are going to be dispersed after July 1st, 2027, that option is going to be gone in terms of what do you call it? Asking for support in terms of economic hardship. So there is a bright spot, which is important whether you're an employee or an employer. So employer student loan repayment assistance, which is up to $5,250 a year. This is tax-free. It's now permanent, and it will adjust every year with inflation starting in 2026. So if you're an employee going to the negotiation table, this is something you can ask for. I mean, it's the law. But if you're an employer, I mean, I don't know how it's going to roll out, and what the consequences are if you don't do it. But if you're an employer, this is something and you're trying to stand out in the market and attract the best talent, then this is how you can position yourself and say, this is something that we do, this is something we care about. And so certainly it's going to open up more conversations about being able to do that, because we've seen that employers have been decreasing how much they're being willing to pay for CMEs. So another conversation for another day, which, by the way, we've been getting a lot of questions about, and we've been asked to put together a workshop on hiring practices for those of you trying to get in and those of you trying to grow your business and find and keep good talent. So you can look out for that in the new year. So let's connect the dots. So you'll take on massive debt to get a doctorate, right? Perhaps I have, because of the podcast, the Mellon Initiative podcast, I've talked to so many people. We talk about money, especially when we're talking about their student journey. And so I know that there are much more economic, not schools that aren't expensive. And that's been a conversation that's come up this week, that some people are hoping that with this change in loan options and repayment, that maybe the schools will finally start to put a cap on their own increase. Because look, the schools, nothing's changing every year. It's the same professor. It's the same lecture. I know, because some of my friends are professors, and they said they record their lecture and they just keep replaying it. When I was a tutor and I was tutoring for the anatomy and physiology course, that was like the prereq for the nursing students, the professor I worked for, he had been teaching 20, 30 years, and he literally was using the same lecture. And he just make a small tweak here or there. We know they put new textbooks on the required and recommended reading, and it might be from a year difference in the publication, the editions. But when you actually look through the book, but when you actually look at the difference in the different editions, it's like a couple of tables, a new dedication page, one or two appendices. It's not worth the hundreds of dollars difference from one book to another. So that's another hack if you're a student. I think maybe I can count on one hand how many times I bought a new book. Mostly I bought the old edition. And then I just found out, so the syllabus will be different because they'll say pages 25 to 40. And in your book, it might not be 25 to 40, but you just look at the content, the information, right? Maybe they're just talking about high blood pressure in this chapter. So you just go find the chapter in that book that's talking about high blood pressure. You read that chapter. It's especially when we're talking about science and the human body. There's not a lot of changes, and the things that are changed, they're probably going to talk about in the lecture. And you can also typically find in your book or go look it up. So that's a hack, saved me a lot of money in addition to renting books and returning them, especially if I didn't think I was going to need them again. But yeah, the conversation about, so the lecture that you're paying for, nothing's really changing except for the amount of tuition that you owe. So it's a one, and then of course the whole conversation about what you're paying, and then you're being asked to look for your own preceptor, and maybe even having to go pay for a preceptor when it's all said and done. So it's a great opportunity to have a lot of conversations, very important and very timely. So let's say, now, if you go to school and you go to a school that's expensive and you take on debt, okay, what we know is that just because we get a doctorate, it doesn't mean that our pay increase is automatically going to increase. But I see some of you in the group chat saying, and I hope my pay will increase. We don't have to hope anymore. We don't hope. Even when I precept, since I've been precepting since the beginning, I used to get new grad nurses who would come in and say, I hope and I guess. And I would stop immediately and say, this is not the practice where we can hope or guess. We either know or we don't know. And so if you're thinking about going back to school, paying money, taking time off, getting someone to watch your children, rearranging your schedule, the stress, losing sleep, sitting in traffic, and you don't know if the person that you're working for is going to be willing to compensate you, you can just sit down and ask and have a conversation before you do all that. They'll tell you if they're going to do it. And if they're not, and that's a non-negotiable for you, that's another important conversation to have, because then maybe it's time for you to walk away, or you can just sit down at the negotiation table, which is one of the articles we dropped on the Mahogany Dermatology this week on what you can actually negotiate for. We taught this workshop inside the Alliance recently too, because everything's negotiable, and negotiations are simply a conversation. They're not an argument. And that's really where you have to do some inner work, because some of these kind of conversations, some people can find confrontational. If you're the kind of person who, if you get asked more than one question, you start to get a little bit defensive, or you're someone who would say they're not confrontational, despite the conversation being just a mature adult conversation, you're going to have to sit down with yourself in order to be able to move past that barrier so that you can sit down and have these conversations. Because I promise you, it's so much more cost effective to keep staff that we have than just the money that it costs to acquire new staff. Even though we know this, the data proves that that it's cheaper to keep them. We know from that 2024 physician APP report that maybe employers don't know this. And if we're talking about employers that are NP entrepreneurs and are new to hiring staff and building out teams and delegating and role and assignments, then maybe you really don't know this, is that it's cheaper to keep people. It's cheaper to sit down and have a conversation, or to hire someone else to have those conversations so you can preserve the relationship. But we know from that 2024 physician APP report that employers are spending more money to attract new talent than to just invest in the talent that they have. And that probably has to do a lot with, patience, frustration, already going through some times or troubles that maybe it felt like it wasn't worth it. But we want to, and you can still salvage that relationship. But certainly if we can help you start to identify some early signs, or just put standard operating procedures in place from the very beginning, then maybe you won't get things that are so severe. Just like our patients, right? We know that if we do education and early prevention and screening, we can reduce the number of people that would show up with advanced diseases and conditions that are either untreatable or terminal, or that are just going to cost so much more time and money than had we caught them much sooner. It's the same thing. Okay, so let's say you take on this massive debt and you don't automatically get a pay increase And then you have also on the other side that you have those fewer repayment options and less flexibility. And so if you hit hard times, there's going to be no deferment for you. That's kind of where the crisis is all about. And that's exactly why so many doctorally prepared nurses might stay trapped in employment structures that undervalue them, taking whatever salary is offered because, they're terrified of their loan repayment, or even because, you're just trying to get your foot in the door when it comes to cosmetics. So if this is making you rethink your doctorate degree, hang on, because I'm going to show you how you can make this all worth it. First, let's talk about the second piece of this bill that really impacts nursing, and that's Medicaid. If you're a nurse practitioner and you already work in cosmetics, dermatology, especially if you serve skin of color patients, rural communities, or low-income patients, this is going to affect us directly. So starting early 2027, states that have to redetermine Medicaid eligibility every 6 months for expansion enrollees. They're also adding work and community service requirements for certain populations. What does this mean in our practice? It means more people are going to lose coverage. More patients are going to experience coverage gaps, and more dermatologic conditions are going to present late stage because patients delayed care. But it's not all hope is lost. And also starting in fiscal year 2027, the bill is going to restrict how states can use provider taxes to fund Medicaid. That's a key mechanism states have used to maintain reimbursement rates. So what does that mean? Medicaid reimbursement is probably going to shrink. Facilities may close or continue to close. We already see they're closing, or reduce or continue to reduce services. And there's a wonderful opportunity for entrepreneurs. Ooh, absolutely wonderful. In rural and underserved areas where many of us work, we're going to continue to feel this first and hardest. And so who's going to get hit hardest? Same people, communities of color, rural populations, provider shortage areas, low-income patients, or older adults navigating chronic conditions. We know that they're our fastest growing age segment of the population, and it's going to continue. The exact populations that dermatology and cosmetic nurse practitioners specializing in skin of color already serve. Often, sometimes the only practitioners who will. And so if you work in dermatology, you already know this pattern. Patients delay care when coverage is unstable. They show up later, sicker, and with more complex presentations. Things like keloids that could have been managed early become surgical cases. Acne that could have been managed to reduce scarring becomes a condition that costs much more money than a topical application. Skin cancers that could have been caught at stage 1 are presenting at stage 3. So let us know in the comments if you're already seeing this in your practice. I know I have. When Medicaid reimbursement drops and facilities close, those of us who build NP-led businesses, the ones who understand how to operate outside of traditional systems, who know how to serve patients regardless of pay, those are the ones who are going to stay open. Those are the ones patients can still reach. So now that you understand what the bill actually is, let's talk about why nursing doctorates are misunderstood, because this is costing us money, opportunity, and respect. If you're a DNP or PhD prepared nurse, you've already heard it. Maybe from colleagues, maybe from your patients, and maybe from that voice inside your own head at 2 a.m. when you're questioning why you went back to school. It's not a clinical doctorate like an MD. You don't get paid more for it. What is even the point? This conversation is happening every day in the group chat. When we measure the value of nursing doctorates against physician doctorates, we're using the wrong metric. We're asking the wrong question, and we're missing the entire point of what doctorally prepared nurses actually do. The DNP degree or the DNP graduate is not trying to be a physician. Think of it this way. The DNP is much closer to an MBA with clinical expertise than it is to a physician. When someone gets an MBA, nobody questions that value. Everyone understands that an MBA holder brings strategic thinking and business acumen, the ability to analyze systems and identify inefficiencies, project management and implementation skills, leadership and change management expertise, all those theories that we learned about, all those change behavior theories, and financial analysis and operational improvement capabilities. Those are your quality improvement metrics, right? That's exactly what DNP graduates bring, plus our advanced clinical expertise in human behavior, masters of communication, problem solving, de-escalation, resource management, the list goes on. As DNP graduates, we can do what MBA does. In fact, our programs are in alignment. You have to find a problem that you can solve, put together a plan to solve that problem, put together a team, and then come back and report what you found. Literally parallel, right? Both of us analyze systems, lead change, improve operations, manage projects. But they don't do them in healthcare settings with clinical credibility and patient care expertise. That's what we have. And the PhD in nursing, they're not trying to compete with medical research. It's designed to generate nursing knowledge, examine how people experience health and illness, evaluate interventions in complex real world contexts, and build the evidence base for nursing practice. That information is going to be then disseminated and taught to other nurses in a nursing school, in a nursing membership, in a nursing conference. Who's going to be standing up there teaching that information? Nurses. So at the simplest explanation, when people say, what's the difference? Why does it have to be different? Because it is different. Because when you go to that school to teach those new students, you need a nurse that's going to be teaching that. I haven't taken one course that was taught by a physician. So I need a nurse that understands and who's going to be there to explain it in the way that I implement care with my scopes and standards and my ethical practice. You have to understand all of that to be able to speak to me. Same thing. Now I'm done with school. I'm in a membership. I'm at a conference. You're telling me what my requirements are to maintain licensure and certification. I need a nurse who understands what that means. That is the simplest difference. If you can understand it, then there is no difference. But if you don't understand it, then I need a nurse that's going to fill those shoes. That's the simplest difference. Both degrees, that DNP and the MBA, building, implementing, studying the systems that make healthcare actually work for patients. Now, hit the thumbs up if you've ever had to explain this to someone who didn't get it, or you're getting it for the first time, and that's okay. It's totally okay. That's the whole reason we published the State of Nursing Education, the 2025 white paper that we released earlier this year that you can access in the Mahogany Dermatology Nursing Bookstore. The link is in the description box. You can download your complimentary copy. We wrote that specifically so you don't have to spend your time answering the same questions over and over, to help those of you trying to decide your path, MD, MP, PA, to understand the difference, and then to see what is it like through that trajectory of nursing education, from high school all the way to doctorate, to being an entrepreneur, and then actually sharing your value to big hospital systems. We cover all of that in that paper. So let's talk about systems level thinking, because if you hear anyone who's promoting doctoral education, you're going to hear us talk about what that actually means. So I'll give you some examples. Let's say you have a missed appointment. All of us know about this. Everybody complains about this. How do you handle that? What do you charge for it? Master's prepared NP sees that the patient keeps missing appointments. That's literally what's in the group chat right now. Now, a DNP prepared NP who understands their role, because some of you are coming out and you still don't understand. You just did the degree because schools are requiring it. It's like saying you have to get married and you just agreed because you didn't want to be alone, but you didn't understand the commitment and the work that's really involved. It's literally the same thing. So, and it's okay. It's okay. That's why we have to all ask questions. And even I don't know everything, because our profession is always evolving. If you're just coming out of school, technically you should be exposed to the latest evidence and information that's out there. So your value is just as important as what I know my value to be to this conversation. So you see that there's patients missing appointments. Now, if you're a doctorally prepared nurse practitioner, and that could be DNP or PhD, okay? 30%, you're going to see this as 30% of patients in the zip code are missing appointments. You're going to say, let me look. Transportation access, appointment scheduling systems, reminder process, cultural barriers, work schedule conflicts, childcare limitations, and health literacy. What does this remind you of? Social determinants of health. Now, let me design an intervention, which means creating new policies, writing standard operating procedures, training staff, building strategic partnerships with transportation services, implementing automated reminder systems, and then measure whether it works. One person can do all of that, or you can literally build your business around just one of those and be fine. Example number 2, let's look at alopecia and skin of color. Let's say you have a master's prepared NP. They say, oh, skin of color patients are presenting with irreversible scarring. Someone just asked this question. She said, what can I do besides minoxidil? A DMP prepared NP says 40% of our skin of color alopecia patients are coming in with misdiagnosis and late diagnosis. Let me conduct a SWOT analysis of our current program, rewrite our clinical protocols, create staff training modules, automate parts of the follow-up process, and establish leadership buy-in for the changes. Example number 3, financial losses. Master prepared NP says we're losing money on this service line. A DMP prepared NP says, let me analyze this payer mix, reimbursement rates, coding accuracy, staffing model, operational efficiency. Here's where we're losing money. Here's why. Here's the fix, which includes developing new policies, creating standard operating procedures, implementing staff training on proper coding, exploring strategic partnerships, introducing billing automation, and providing leadership development. This is MBA level thinking applied to healthcare. And it's exactly what DMP graduates are trained to do. Now, what most NP entrepreneurs either don't understand, don't care about, or don't have time for, this is what they have said. I'm just repeating it back. Writing and implementing formal policies and standard operating procedures, conducting SWOT analysis, designing and delivering staff training programs, building strategic partnerships that create operational efficiencies, identifying what can and should be automated, developing leadership structures and succession planning. DMP graduates are trained in all of this. It's literally what implementation science and quality improvement methodology teaches us to do. Common systems, if you want a whole video on how to apply this in your practice. Now, let's connect the debt to compensation. And so this is where we bring it all together. So you're right, getting a nursing doctorate doesn't automatically increase your salary. In many traditional employment settings, a DNP or a PhD makes zero difference in your paycheck. And now HR1 just made the problem significantly worse. And that comes as a surprise to some of you who are literally applying to school right now, because where you're at, you're not making enough and you're thinking if you get another degree, it'll make the literal difference. But you're going to hear me say this a whole lot. When you get that new degree and you go apply for a job, what's separating you? Because someone else applied with that degree. Someone else applied with clinical experience. Someone else applied with passion. What else are you doing that's going to stand out and specifically help that business grow? But that can be equally fulfilling for you. Just because you're helping someone else grow their business doesn't mean you won't get anything out of it. So let's say you graduate with that debt and you have fewer options to manage it. Your doctorate doesn't automatically increase to salary pay. You'll be facing 30-year repayment timelines with no hardship deferments. That's exactly why so many have stayed trapped and alone in employment structures that undervalue us, taking whatever salary is offered because we're terrified of repayment, or we're terrified of payments. Now, this is the best part. The problem isn't the credential or the degree or that nobody understands. It's our negotiation muscle. Others are not going to value or pay what we're worth until we do, and until we can clearly communicate it. When we walk into salary negotiations and accept the first offer, or worse, accept an offer out of desperation because of loan payments, we're not just undervaluing ourselves. We're setting the market rate for every doctorally prepared nurse who comes after us. This is why learning the art of negotiation isn't optional anymore. It's mandatory for survival. It's not about your pay. It's not just about your paycheck. Because when you negotiate transparently and successfully, you're negotiating for all of us. And when you accept lowball offers out of fear, or because someone told you just take whatever you can get to get your foot in the door, you're telling employers that doctoral preparation doesn't matter, and that they can continue hiring DNPs and PhDs at the same rate as master prepared NPs. That affects every single one of us. And then if you agree to a salary that doesn't allow you to pay for your, afford your cost of living and pay back your loans, you're going to get another job. As an employer, I see that you're stretched thin. Now there's a liability. Are you going to show up for work? Are you going to get hurt at the other job? Are you running back and forth? You're going to be late because of traffic? So you taking on all these other stressors makes you more liable. Right. So I also benefit from making sure that you're properly compensated. So the great thing, you don't have to negotiate for yourself. Just look around. So many other industries, it's standard practice to have someone else negotiate on your compensation. Actors have agents, authors have literary agents, professional athletes have agents, executives have headhunters and legal counsel. because this allows a third party to negotiate to protect that working relationship. When your agent asks for more money, the employer doesn't see it as greedy, they see it as business. In nursing, we've been doing this, a different version of this for centuries, but we call it advocacy. Here, we advocate for our patients every single day with insurance companies for better coverage. We push back against hospital admin for safe staffing. We've been collective bargaining for unions for decades. We know how to do this. We just haven't been applying it to our own compensation. I want you to share this with another NP who you know needs to hear this right now, okay? And here's the other thing. We often think negotiation isn't just about it's not just about salary, because everything is negotiable. Let's go down the list. So you have your base salary and you have your bonus structures. It could be sign-on bonuses, it could be profit sharing, holiday, anything you think about. Performance. You have student loan repayment assistance, which is now going to be up to $5,250 a year, tax-free. That's going to be permanent, and it's going to adjust with inflation. Retirement contributions, health insurance, that CE budget, work schedule, vacation time, remote options, protected research or writing time. I would love that. Publishing support, conference funding, scope of practice and autonomy, title changes, access to networking, corporate events, corporate retreats, contacts, intellectual property rights, non-compete clauses. Negotiate these down or completely out, even those non-solicitation clauses, severance packages. Everything is on the table. You just have to know if it's negotiable. You just have to know it is negotiable and be willing to ask. Maybe it's even equipment, supplies. Just look around you. And remember, the compensation doesn't come from the credential. It comes from understanding what the credential enables you to do. And refusing to accept less, that's what that's worth. That's less than that's worth. We can't do that anymore. We cannot continue to refuse to accept less than what that is actually worth. With HR 1 making educational debt more burdensome and repayment less flexible, we can't afford to keep accepting offers out of desperation. That's become like our mantra lately. We need to negotiate like our careers depend on it, like our practice depends on it, because it does. We see this happening right now. So we've covered what's changing and why it matters. Now let's talk about what you can do about it, because it's not over. This story is not over. First thing you can do is sign a petition. Major organizations like the American Nurses Association, National Association of Pediatric Nurse Practitioners, the National League for Nursing, American Association of Colleges of Nursing, American College of Nurse Midwives, they've launched a petition asking the Department of Education to include nursing in its proposed professional degree program. 25 nursing organizations of color released a joint statement responding to the proposed federal limitations, asking the Department of Education to engage nursing stakeholders, to include post-baccalaureate advanced nursing degree programs, and to recognize nursing as commensurate with other health professionals. Organizations like the Alliance of Cosmetic Nurse Practitioners, DNPs of Color, the Asian American Pacific Islander Nurses Association, the International Association of Latino Nurse Faculty and Nurse Leaders, the National Association of Hispanic Nurses, and the Society of Psychiatric Mental Health Nurse Practitioners of Color, to name a few. This demonstrates our collective nursing voice before regulations are even finalized. Every signature matters. Nursing has always been a collective. You don't have to know everything. I think I've talked before, when you get on board with things like policy, we give you everything from scripts to emails, when to show up, who to contact, when to contact, numbers. All you have to do is raise your hand and say you're willing and able. That link is going to be in the description box for that petition. You can pause the video right now and go sign it. Oh, wait. Okay. Now, here's what else you need to know. The law hasn't passed, but the Department of Education still has to write the actual regulations that implement it. And federal law requires them to ask the public input before those regulations are finalized. It's not optional. It is the law, which means we have a narrow but very real window to influence how these regulations are written and whether nursing is protected or thrown under the bus. So this is how it works. The department is currently drafting the proposed rule. When they're done, they'll publish something that's called Notice of Proposed Rulemaking, or NPRM, in the Federal Register. Once that's published, a public comment period opens. That's when anyone can submit formal comments via regulations.gov. You don't need to be a policy expert. You just need to be able to explain how this will affect you your students, your practice, your community, and what you recommend instead. Every single comment submitted has to be reviewed by the Department of Education. Like I said, that is the law. When the NPRM is published, here's how you can make your voice count. Number one, be very specific about which part of the proposal you're responding to. Reference the section or page number. Right now, you can go to the Mahogany Dermatology blog. Like I said, all week we released 5 articles breaking down the bill. Article number 5, titled Trump, Nursing Professional Degree Changes, How to Fight Back Through Public Comments. There's a table in there. It shows you 2 specific sections in the bill that you can name when you go to leave your comments and talk directly, specifically about how it's impacting you. We even, for those of you who are on our email list, we emailed out in that article, there's a link to a toolkit, and it has everything, all your questions, everything that you need. Copy, paste, send, share, the whole 9, okay? Number 2, share your impact, use your experience, use real numbers, use your students' situations. Number 3, offer clear recommendation. Don't just identify the problem, propose a solution. Those things we call nurse hacks, that's innovation, that's solutions, because we're problem solvers. Number 4, cite data or experience whenever you can. And if you can't think of anything, just turn to the nurse next to you, they'll help you out. If you want to be added to our email list, go to mahoganydermatology.com and contact us and put your name in the box and say you want to be added to the list, and you can get access to all this stuff firsthand as soon as it's available. But yes, download the toolkit and let me know if you find it helpful. So let me give you some other strategic moves you can make right now, in addition to signing the petition, in addition to downloading the toolkit and sharing both of those with your network. If you're a PhD nurse or in a PhD program, here's some dissertation topics for you, because HR 1 just created a national experiment in health policy. Start drafting your research questions. How does Medicaid coverage instability affect dermatologic outcomes in skin of color populations? What are the barriers to early intervention when patients experience coverage gaps? How do student loan policy changes affect graduate nursing enrollment and career decisions? If you're a DNP student and you're looking to do a QI project, although you can do other ones, right? Evidence-based practice, policy is a great policy one. Here's one for you. We got 3 options. Implement telehealth models for patients losing coverage. Building community partnerships with safety net clinics. I love that. I love that one. I can see that being nurse-led all the way. And creating sliding scale payment structures. Even if you just understand sliding scale payment structures and want to build a whole business around helping other NP-led businesses adopt those and manage them, look at the data, see how it's working, make some tweaks. That's a whole business. That's a whole business model. And you can pick any specialty that you want and niche down, and boom, now you're in your favorite specialty. For all of us, we need to start thinking about where we can publish and present this work. I'm talking about different journals, practical implementation of science, of nursing science, founded by a good friend of mine, Dr. Kimberly Souffrant, who's a PhD trained NP who works in emergency medicine. She's one of the co-founders of this journal, as well as the Souffrant Institute, and she works with TRAIN at Mount Sinai in New York, and that's a collaborative between PhD and DNP nurses. She was just here. Since I've seen you the last time, she's come to Houston. She did a whole presentation at the Houston Research Institute on motivating a room full of nurses to be part of innovation. They flew her from New York to motivate people to recognize what we do every single day, which is solve problems. That's really what innovation is solving problems in a different way. And every day you show up for work with changes and limited resources and new staff, you have to solve the problem in a different way every single time. Just like now with the policy changes, you got to do what you've been doing in a different way. Another journal, the Journal of Cosmetic and Aesthetic Dermatology and PPA Dermatology Perspectives. I'm on the editorial board there. The Journal of Dermatology Nurse Practitioners and the Journal of Dermatology for Nurse Practitioners and Physician Assistants. We have so many of our friends over there that have been forces in dermatology for multiple decades. We have the Journal of Dermatology Nurses Association, and of course, the Journal of the American Association of NPs. Pretty much all of these that I've named have annual conferences that you could also disseminate information. especially the AANP National Conference. You're going to, nursing is not shy when it comes to policy and making our voices heard. And so that would be one conference for sure. They wouldn't have a hard time presenting your case and why it matters. And all those links are in the description box. Now, if you're an NP entrepreneur, you can audit your business model right now. Is it sustainable if Medicaid reimbursement drops? If your patient population experiences coverage gaps, what will you do? Start building hybrid payment models that aren't payer dependent. Develop those community partnerships, put your telehealth infrastructure in place, and create some educational products that generate additional revenue. Because when these systems contract, the NPs who survive and thrive are the ones who built businesses who work regardless of insurance status. So as we wrap up, just remember, HR1 isn't just policy, it's a signal. It's a signal that systems we relied on are shifting, that the patients we serve are going to need us, not less, but more, that the gaps are widening and someone needs to step in, and that somebody can be us. Because here's what I know about doctorally prepared nurses. We don't wait for systems to fix themselves. We design the interventions, we publish the evidence, we train the next generation, we build businesses, and we lead. We don't just rely on policy changes. We anticipate them, just like we anticipate problems with our patient. We prepare for them, just like we prepare our patients. We build models that work regardless of what policymakers decide next. That's what it means to train founders and not followers. That's how we turn policy challenges into leadership opportunities. And that's how we make sure that when patients need us most, we're still here, still open, still serving. Now, what I need you to do before we leave this video is sign the petition. That link's going to be in the description box. Subscribe to this channel if you haven't already. Hit the bell so you'll know when I drop a new video, when I go live, and certainly when the public comment period opens. And then share this video with a DNP student who's questioning whether the degree will be worth the debt, a PhD candidate who needs to see research opportunities, one of our NP colleagues who's undervaluing their expertise, or a program director who needs to understand what's coming. And then check out the full article series that we have breaking this down for you. In there, you'll see that toolkit that you can download. It's complimentary, as well as a link to the podcast, which describes everything for you in audio format. If you're ready to build founders level practice or business, right? Because just because you take care of patients doesn't mean your business has to take care of patients. And this business works regardless of what policymakers decide. Then we would love to have you come over to the Alliance of Cosmetic Nurse Practitioners, where we build founders, not just followers. We're there to not help you to blend in, but to stand out and to build legally sound, ethically grounded, and financially fulfilling careers in dermatology and cosmetics. You can find that link in the description box, or you can visit cosmeticnp.org. And look, I know it's a lot, a little bit longer than we normally go, and I know it's heavy emotionally, not just listening. Like, there's emotions involved with all these changes. And I know you might be feeling a little bit overwhelmed and worried about what this means for you. But remember, you're not in this alone. Nursing is a powerful force. We know it. Now let's make sure the Department of Education knows it too. Before we sign off, this is a very special week here at Mahogany Dermatology Nursing Education and Research. This time last year, I was closing the application for the Mahogany Telederm internship, which is now the Mahogany Dermatology Nursing Internship. And at that time, we welcomed our first intern, Jade Trevino. And as I record this video, we have just days left until her internship period closes. And I just want to take this time out to thank her personally. I'll dedicate a whole video to our experience. And actually, maybe Jade will come and do an interview with me and we can talk about our experience together. We've spent the whole year sharing our reflection, sharing reflection articles on the Mahogany Dermatology blog. And once we finish the 12th one, we will be releasing the Mahogany Dermatology Nursing Framework for internship development. And I know a lot of my friends also try to implement their own internship, and some have been successful and some haven't. And I'm just so grateful that my first experience helped me find Jade, who happens to be right here in Houston. At the time, I wasn't living in Houston, and that we've been able to develop a friendship and accomplish so much in this 1 year. And I for one, am just so proud of her and all the accomplishments that she's made. in less than 12 months. Honestly, most of the things that she's done, it was less than 12 months. And before she applied to this internship, she had just gotten fired. But since then, when the internship closes, she will have published 12 articles for us. She became the blog chair for diversity in dermatology, where she's published up to 4 articles. She went from 0 to 2 conferences. She published 2 websites, one for her company, Go Skin Check, and one with her name, Jade Trevino, where she established herself as a thought leader in nursing education, research, and entrepreneurship. She helped me launch the Alliance of Cosmetic Nurse Practitioners, where she has provided 2 invaluable services to us. First was creating and teaching our workshops on foundations in cosmetic business, the key to helping someone get started, to building financial wealth and experiencing the freedom that we're talking about. And then helping us create our protocol to become ANC accredited, which just adds immense value to our members. And so incredible work. At the time that I'm recording this, we are just clicks away from submitting our first publication together on AI and dermatology. And it's just amazing all that's happened in the last year and how all those things now tie into the work that we're doing now, but at the time had no clue. So I just want to thank her, and I'll come back to do some more. But as we wrap up this internship, of course, it's time for the next one. And so that application will be opening on December 22nd, and that application will close on January 22nd. It includes a tiered process to getting accepted. If you have questions, you can certainly email me. You can even schedule a video chat if you want to ask those questions in person. But stay tuned through these videos and by joining our email lists and paying close attention to the Mahogany Dermatology blog, where all announcements are shared publicly. I thank Jade for participating in this public experiment, and for all of you who supported us along the way. It's Batch Content Day, so I will be back to film 7 more episodes. If you're here, I welcome you to grab some water and some snacks and bring your questions. And then I'll see you in the next one. For everyone else, I thank you all for watching. And I'm changing times. So, and I can't even remember what I used to do, but we're changing times. New videos will drop now on Tuesdays at 10 a.m. Central Time. So no longer on Saturday. Or was that Friday? I don't even know. This is my 3rd change. But right now, new videos are going to come out every Tuesday, 10 a.m. Central. This one in particular is a special one because we have special things happening in nursing. So you're seeing this on a Sunday, but moving forward, it'll be every Tuesday. Because I also changed the podcast. The Melanin Initiative, now we release those episodes on Saturdays at 7 a.m. Central, but we still drop the podcast audio at 5 a.m. on all your favorite podcast apps. So our night shift friends can be the first to get something and not the last. So if you subscribe to the channel, you'll see when new videos drop, just in case I make any other tweaks between right now and when everything is published. But I thank you all for watching, and I'll see you next time.